Thank you, Jonah. Appreciate the opportunity to be here and talk about this. Now that we've all been educated, we need to figure out how we can educate our patients. Here are my disclosures. So the scope of the problem personally for me as the surgeon is that I view that opioid post-op use slows patient recovery. But the real bigger issue for the society and in our nation is that this is what is contributing to the current opioid epidemic. And the reality is that although surgeons only provide about 10% of opioid prescriptions, the rate of prescription is the second highest after pain medicine specialists, and we need to recognize that. There's significant variation in the way that we all prescribe medications, particularly even through the same procedures. And many patients undergo surgery may not even be given adequate information about the opioids or other strategies for postoperative pain management, which we've heard about earlier today. In addressing the epidemic, there needs to be a greater emphasis on educating our patients so that they can learn to use the opioids appropriately. So where to begin? Managing expectations. This was briefly mentioned in a previous talk and left for me to go through, which I appreciate. Expectations can often be completely different than reality. And we need to make sure that our patients know that we both want to have minimal pain, but that does not necessarily mean that you need opioid pain medication. When patients come, I'm a colorectal surgeon, I do a lot of complex abdominal wall reconstruction. Patients come in your office and they talk about these surgeries and they just assume maybe their mom had a surgery or a friend went through something, they're gonna be in the hospital for a week. They definitely expect that they're gonna get their pain prescription. A lot of times the patients are asking for that at the pre-op consultation. Let me just fill it now so I already have it. And many patients think they're going to be in pain for up to a month. They want you to fill out their disability paperwork for an inguinal hernia. Maybe that's what they wanted anyway about having the operation. So the time to change this expectation and turn it back into the reality is in the pre-op setting. I like to advise my patients, even colorectal patients, MIS, that my patients rarely require a post-op prescription of opioids, and that if they do, they might only use it for a day or two. And I tell them, you're only going to get a prescription that would even last you a day or two anyway. I also like to discuss with my patients the surgical techniques that I do that specifically reduce pain. And I also like to show them pictures. It works the same way as a plastic surgeon does. I think that we can all agree, even the lay public should agree, that this complex Crohn's operation is less painful than the same operation in this person. So how do we do optimal patient education? Well, we've heard a lot from the previous talks about the non-opioid strategies. We need to educate them on the appropriate use, the side effects, the risks, and proper disposal. And the goal should be to enhance recovery while reducing the reliance on opioids, lower the addiction, limit the supply that would otherwise then be misused. There is abundant evidence that preoperative education of our patients works to help reduce opioid use as well as enhance recovery. Earlier cessation of opioids, less overall consumption, better adherence to opioid disposal, better patient-related experience overall with their pain. But where are the gaps? The bottom line, we do not do a good job at educating our patients. An inadequate education regarding postoperative pain management is liable to result in the poor understanding, compliance, and actually worse pain control. Without education, opioid misuse is fairly common. Misuse is things like taking larger doses than are prescribed, taking them for an extended period of time, saving unused pills, sharing them. And that's especially problematic because when they're prescribed in excess, it leads to a significant amount of unused that people are keeping on their shelf, and maybe they'll think they'll just take it for a stubbed toe now that they have it. So the guidelines for patient education always starts with getting on the level with your patient. If you've been to some of the other talks, you've heard about this, but the AMA recommends that for any patient-educated material, written instructions should be on a 6th grade reading level. If you were to talk to patients the way that you heard our presenters here, they might hear what you're saying, but they do not understand it at all. So you explain to your patient, you are going to have pain. And pain is typically most significant in the initial few days after surgery, but it improves. And the role of pain control is not so that you feel no pain, but it's that you can do all of the things that I'm asking you to do. Get up and walk, get out there. Okay, go back to normal life. So opioids can be used. There shouldn't be a taboo over it, but they should be limited to pain intensity that interferes with activities that are not covered by the non-opioid strategies. They should be used for the shortest duration possible, and the goal is to taper and discontinue them as soon as possible. We heard about multimodal anesthesia. I'm not going to go through that. Side effects are very important for patients to understand what they can happen if they're using it for prolonged period of times or escalating doses. And this helps to limit the high-risk behaviors. The side effects are always dose-dependent, and we've heard about this in previous talks as well. And it's important that the patients know this up front. Particularly as a colorectal surgeon, I would hate that any of my partners have to hear from my patients, I can't poop after surgery, I wonder why. Addiction, they need to be taught the terminology, much the same as what you heard Jonah tell us. And addiction can actually occur even after 5 days of use, and this increases with longer durations, particularly if you have a patient who's calling for refills. I have a policy in my practice that the patients know preoperatively we will not call in refills over the phone. You got a problem, you come in to be seen. Safe practices. The patients need to understand that opioids are to be taken only as prescribed to avoid misuse. Misuse, we talked about it briefly before, but escalating doses and frequency, taking it to sleep, crushing pills for faster onset, and mixing with other sedating medications or alcohol. Storage and disposal, I will admit I often don't necessarily talk too much about this, but I will use the excuse that I usually only give about 5 pills post-op. But it's very important the patients know this. When they're done with their medications, they need to get rid of them. They need to be safe when they're handling them in the home. They got to keep them away from their children. They shouldn't share them with friends and get rid of them. And you need to tell them about take-back programs and other places that they can go to get rid of their opioids. So methods of education, there's a bunch of different ways you can do it. Written pamphlets, in person, that's what we do in the consult office, web-based, video-based. All of these, I think, are good adjuncts. They all have their pros and their cons. Who and when of education? This is a multimodality thing. It's our anesthesiologists, it's the surgeons, it's the primary care. Surgeons should be the ones who are educating directly to the patients up front and setting the stage. It's also important that we make sure that we have buy-in for their friends and family, so a patient doesn't go home and say, the doctor told me I could get thousands of pills, and then the family's calling for refills, and you're saying, I never said that, and then they're angry with you. This can actually just be part of your ERP discussion that was mentioned before. ERP has consistently been shown to be associated with a decrease of opioid use. We heard what our anesthesiologists can do, particularly with regional anesthesia. I always let them do their blocks. They can bill for it, and they do a better job at it than I do. And you also need to make sure that your nursing staff and house staff or anybody else ancillary, nurse physician extenders, they need to understand this as well, as often they are the ones who are writing the prescriptions upon discharge from the hospital. Where do I start? Become aware of what's already available to you. Check with your institution, check with your anesthesia department, check with your pain service, and check your society resources. All right, the American College of Surgeons has wonderful pamphlets that you can download from here. There's a 6-page PDF that goes through everything that I have just told you, okay? And it's written in a level that your patients can clearly understand. And as Jonah mentioned right at the beginning, is Tonia's baby project. And it's not a baby anymore, it's out there, but many of us don't know this exists. So if you go to the SAGES website, go up to the top, click on education, there's Opioid link right there. It takes you to this website that goes through everything that you have heard here. What you're looking at here is what we learned, but then in this patient education is everything that I just talked about here. So the resources are there available for you. This is just to reinforce to us and to our patients everything that you've heard in this session, and I really think that we should take better time and attention to all of this. Conclusions, don't underestimate the role of educating your patients. Don't underestimate your own role in this process. The education does lead to decreased use and safe use, and this leads to happier and more satisfied patients while combating the crisis. Thank you very much.